first of all, I also want to thank you all for your really big efforts in this class. This class is challenging. I'm not going as far as to say it's hard, but it's challenging and it's different. And I said that at the beginning and I meant it, and now you know. But you all put a lot of effort in and worked really hard. And I think in clinical you worked really hard as well. So, and that's the feedback that I got from Mrs. Olson as well. So for those of you who have her, you worked really hard. And I'm proud of you for that. So good job, well done. I baked for you. So
thank you.
Chocolate chip cookies, okay. So hopefully y'all like that. I tried to make something kind of generic so that everybody would like it, or bring it home to somebody who will like it if you don't like it.
Thank you.
You're welcome. So our last lecture today, age-related. So you know, we saw in the readings, we just kind of were bouncing around a little bit because we're just touching on some things. Some things, especially where the kids and adolescents come in, we kind of covered that already in the other sections. And then the same thing with the older folks. We're just kind of touching on a couple things that didn't really apply to other places. Okay. Before I forget, note to self, and there I forgot it. The course evaluation. So you know, you guys all did your clinical evaluations already. You did them online. My course evaluation is the same way. Okay, it's going to be in Blackboard, and it's the one that evaluates the course itself. So this is the lecture half. So this is for me. You need to do that sometime before Thursday. Okay, sometime before the end of the course. So I will make sure that that's open when we're finished. It should be, but that doesn't mean it is, for sure. So I'll make sure that it is, and if you can just hop in, it's just a handful of questions. It shouldn't take very long, okay? So if you can do that, that would be fantastic. All right. Let's see. Got to find the beginning. There we go. Okay. We're not going to spend too much time on eating disorders. I bring this up in here because it doesn't really fit anywhere else. So we're just going to talk about a couple things. We're going to distinguish the difference between the main two, which are anorexia and bulimia. There are others, but we're not really focusing on those. And then we're going to talk about how people feel when they have an eating disorder, what kind of drives those. So, and there are some commonalities, and then there are some things that really do separate them. So anorexia nervosa, so remember when you were back in 1201 and we talked about how anorexia in and of itself is just what? Loss of appetite, right? So you don't feel like eating, but when we attach nervosa to the end of it, now we have a disorder, right? So people with anorexia nervosa have an extreme fear of weight gain. They usually have a disturbed body image. And their weight is generally less than 85% of normal. So their BMI slips really, really low, usually below 18th on the percentile. And then women will stop getting their period once they're under 18% as well. So once your BMI goes below 18, then the periods usually stop. And that's not uncommon. So it can be restrictive, which is the usual. So there's extreme dieting, there's extreme fasting, excessive exercise, these types of behaviors. It's very much a control, right? Controlling what's going in. And the home environment is often high pressure. High pressure to do well and succeed, okay? And then there can also be the binging and purging. So sometimes we see that with anorexia as well. And to be diagnosed, it has to last 3 months, the symptoms. And then bulimia nervosa is mostly binging and purging. These individuals usually have a normal or higher BMI. And now we're looking at some other things just for your own information. Binge eating disorder is new. It'll be new to the DSM. I'm not sure if it's in 5, but they're now recognizing that as an eating disorder where people just plain binge eat large amounts of food. They don't necessarily throw it up, they just eat it. Pica is when people eat stuff that's not food. It's real common in pregnancy for women to want to chew ice, and that is a form of pica, yeah. And actually they attribute that to low iron for some reason. There's not really ice doesn't do nothing for you. It doesn't give you anything, but for some reason people will have that. Little kids often eat clay or dirt or lead paint, and those are forms of pica, okay? Sand, rocks, chalk, things like that, starchy things, okay? They don't have nutritional value. And they're now also looking at considering obesity or BMI over 30 to be an eating disorder as well. And we can't forget our male counterparts that do suffer eating disorders. Sometimes people look at eating disorders and just consider them a female problem, but they're not. So for athletes, models, things like that, and also people with gender identity issues and sexuality issues. So this is another population to be aware of that may have issues with eating disorders. Okay. So there's lots of factors that go into them. There can be biologic connections. There's, of course, we know a big genetic connection for obesity, about 80% actually, when you have individuals who pass on to children. So we know that there's some of that. We know that exercise gives us endorphins, which make us feel good. So it's not hard for people to become addicted to exercise. So if you have that mindset already, and then you get that runner's high or whatever it is you get, sometimes people can excessively exercise and then get addicted to that feeling, the good feeling that comes after, okay? So psychologically, people with eating disorders often have low self-esteem. And when I talked about control, losing weight, it can be a form of, and starvation can be a form of punishment. You know, it can be a form of, this is what I'm controlling in my life. Other people are controlling around me. So when you have the controlling parent set that demands the straight A's and the best on the team and this, this is something that I'm controlling that no one else can tell me that I'm going to do, okay? So those parental expectations are high. And so they do it to satisfy their emotional need, okay? That's what they're doing. And then of course societal factors are just the plain usual stuff, right? Out there on all of the media and everywhere else are the beautiful people that are skinny and perfect. And this is something that we see from the time we're small, right? And so as parents and as adults and as healthcare providers, we have to be really careful about what we bring forward. Even the words that we use. You know, my husband is a metabolic syndrome, so we have to eat pretty good at our house, but just thinking about, you know, eating healthy, you know, not eating to lose weight, not using words like fat, things like that, because there are girls in my house, and they hear this, you know, and they're, and all through from the time they're small, they start thinking about these things, what that means. So we have to be really careful. Let's see, what else do I want to mention about that? And then, of course, you know, when you get to the adolescent set, of course, high school is all about fitting in. That's the only thing. You know, recently I thought it was interesting, a counselor said to me, high school really isn't about grades at all. It's a completely social thing, and it really is. You know, think about all the changes and growing that we do during those 4 years. It's really about, you know, peers and interacting and learning how to navigate as almost adults. Versus, you know, yeah, grades in school are part of it, but that's not really what we do in high school. So, common symptoms. People will measure their worth by their weight and their amount of body fat. Body image, low self-esteem, we talked about that. Perfectionistic traits, okay. Preoccupation with food or a refusal to discuss food. So you can kind of see it could go either way. Our oldest, when she was first on first antipsychotic, she was on gained 60 pounds. Now, I always mean to put the pictures up, and I always forget to do it, but I have before and after pictures. I say 2 afters because she was just one of those kids. When she was a year old, she weighed about 20 pounds. She's just always been a little bit wiry. That's just her natural build. And she stayed that way until she was put on risperidone. And then she gained an enormous amount of weight for her. And it was definitely the meds. It was a side effect. We knew that, but you know, we're trying to do what we're supposed to do, try to do what they tell us. And she was absolutely miserable. And she went through a period of really, really strong restriction. And she could just tell you things like, we'd go through the Starbucks, you know, and I'd be like, oh, do you want a tea or you want a what? And she would just right there list it all off for me. This is how many calories, has this many carbs, this much sugar, blah, blah. Like at any given moment, an apple, or whatever. She would just zip it all off. And I think, why do you spend so much time on this? You know, like, but this is what she was doing. And she took all that weight off and she got too thin. And then fortunately it kind of leveled off. And now she's a little bit more back to her own normal. She weighs probably about 120 pounds, which she's my height, so that's about right for her. But when when you look at the picture, she doesn't look like the same person, you know. But she got very tight about the food, and she could tell you everything about the food. And I think that the reversal happened with some of that because she started getting dizzy. She started getting dizzy trying to go to work and do her thing. So for her, that was sort of her signal. I need to stop doing what I'm doing. Sometimes they fear not being able to stop once they get going. Substance abuse can be related. If they're binge eating, there's a lot of hiding. Getting the food and hiding it so no one can see it because it makes them feel ashamed. Okay. So there also might be stealing or shoplifting, that kind of stuff. For anorexia specifically, so remember way back in the beginning we talked about what a disorder was that was egosyntonic, and that isn't a disorder that goes along with our beliefs, right? In our mind, it's okay. And anorexia is a good example of that because it's good to eat healthy, right? It's good to exercise, right? Those are things that our culture values. Those are things that make me a healthy person. So in my mind, I can say, well, these behaviors are okay. These are good. I'm doing the good thing that people say you're supposed to do. I'm doing it to an extreme, and I don't see that, but it's a good thing. Early onset, really, really common. Apparently now, my kids have sort of opened my eyes up to some of the stuff that's out there. There are what they call pro-ana groups on social media. They're actually chat rooms that promote anorexia type behaviors and the disorder itself. Mm-hmm. So you have to be really careful. It's easy for people to fall into these. Amenorrhea, again, after the BMI dips below 18, periods will stop. And the reason for that is that you store your estrogen in your fat. So when you have no fat, you have no place to put estrogen, and then you get heavy on the progesterone, low on the estrogen, and your period stops. Okay, it's kind of what happens to you when you're pregnant. Progesterone goes up, estrogen levels off, no bleeding. People become bradycardic. Of course, the metabolism is going to slow because what fuels our metabolism is putting something in. Nothing's going in, everything slows down, right? Dry, flaky, cracked skin. So think about someone who's not eating is also often not drinking or not drinking very much, so they may become dehydrated. And they're also losing a lot of vitamins, minerals, that kind of stuff. Constipation, common. Hypothermia, brittle hair, nails, that sort of stuff. What about lanugo? Do you guys remember what that word is?
It's like the hair from your baby.
Yeah, pardon me, when babies are born, that little fine downy hair all over them. And that's a mechanism to keep them warm, because the last thing that a baby develops before they come out is fat underneath their skin to keep them warm. So they get this fine downy hair actually very early on in the womb, and then it starts to slough off at the end once they get that fat layer to keep them warm. So a lot of times when they're first born, they still have it. So when people's BMI goes really, really, really low, they actually grow that back as a way to keep their body warm. So your body is amazing. It does these things for you. And then sometimes you see rotty teeth, because if they're puking, all that acid on the teeth, right? And then, so bulimia then is the opposite in terms of it being an ego dystonic disorder, because is it socially acceptable to eat a bunch of food and barf it back out? Not really, right? So they're ashamed. They know their behavior isn't normal and they're ashamed of it. So that's kind of the opposite. It often starts later in later adolescence or even young adulthood, using things like laxatives, diuretics, that sort of thing. Does anybody know what Russell's sign is? Did anybody read about that? Russell's sign is when someone develops a callus round about their third knuckle from their middle finger or first finger. When you stick your finger down your throat to make yourself throw up, your knuckle grazes your teeth. And when that happens over and over, you get a callus. Okay? So this is something that we might notice on assessment. Okay, remember, when you do things like assess people's skin turgor, and when you do things like assess people's cap refill, we notice all sort of things, right? You pick up someone's hand, you're feeling the temperature, you're getting their radial pulse, you're coming down to the fingers, you're checking that cap refill. There's lots of things we can see, right? We just pay attention, okay? Esophagitis from the acid in the throat, parotitis, did I say parotid? I don't know. These parotid glands under here, you know how your mouth waters real bad when you're going to vomit? Okay, that's all under here going on, and so these glands will get swollen chronically from vomiting so much, okay? And then, of course, their electrolytes are going to be all wonky. So, for anybody who maybe knows someone who's had an eating disorder or suffered an eating disorder themselves, I just put the trigger warning up here because I'm going to show a slide of a picture that's not pretty. So if you don't want to look at it, don't look at it. You don't have to, okay? This here's Jeremy. Jeremy was a model, as you can see from the one picture. And then he off and on struggled with anorexia through his young life and through his career. And then as he got older, he struggled again. And unfortunately, he died from his disorder. And the usual cause of that is heart failure. Okay? That's the usual reason. Anorexia is one of the hardest mental illnesses to treat successfully. It's extremely difficult. The behaviors become really, really ingrained, and helping someone see themselves in a positive way, body image-wise, is really, really tricky. Because of all the fluid and electrolyte imbalance, because of all the strain, heart failure is usually the cause. So if you're dealing with a person who has an eating disorder, there aren't any around here anymore. Peoria at OSF used to have an inpatient eating disorders unit. Now I think you got to head more towards Chicago to get that. But again, like when we think about raising self-esteem, a lot of you dealt with this in choices, right? Your patients there, helping them identify their positive qualities, and remember, we need that to come from them, not from us. So we want them to talk about any one positive thing and then build off that. Rewards for gaining weight and not purging. Usually in these units, the staff eat with the patients, because what we're trying to do is normalize eating. They're used to, if they eat it all, they do it by themselves. It's like, it's very, what's the word I'm looking for? Controlled, I guess. You know, how much goes on the plate, how much goes in the mouth. And it's not a social activity anymore, but if you think about it, eating is a social activity, right? You have dinner for your family or with your family, everybody sits together, there's a lot of chattering going on a lot of times. So we turn it back into that, normalize eating as a social behavior. And then they're not allowed to go to the bathroom or leave for an hour, hour and a half after to avoid the purging and that kind of stuff. So relaxation and coping skills for anxiety. A lot of times patients might be pre-medicated with an anxiolytic prior to a meal because eating causes a lot of anxiety for them. So this is a technique that's often used as well. And then, of course, therapies and stuff. There was a really good series on Netflix. Of course, I don't remember what it's called now, because why would I? What's that?
I think it's called To the Bone.
To the Bone, maybe? And they showed people with eating disorders, different eating disorders, living in a house, like a residential setup, but it was a house. And it was really interesting. And a lot of them did very well, actually. It was a really good setup for them. Sometimes they use mirror therapy, so it's being able to help people view themselves in a mirror. Another technique I saw once where they laid, remember when you were a little kid, you made drawings of yourself in kindergarten by, you laid butcher paper on the floor, and then you lay on top of it, and your friend would trace you. And they would do this because it provides a visual that this is actually what you look like. Because when they look in the mirror, they just see fat. They can't wrap their head around that's not what it is. So it just helps provide an actual visual. With exposure therapy, right? And it's all about managing the feelings, just like every other mental illness, right? Managing whatever's going on underneath, whatever anxiety, whatever need for perfection, need for control, giving the patient back that so that they can then manage the next thing, okay? So they use Prozac for bulimia, anorexia. These are just common, you don't have to know, these are just some common things that we use for these disorders. We mentioned Marinol in PhRMM for an appetite stimulant. Remember we talked about that a little bit with your last lecture. So there are some medications that can help. Okay. Client teaching for eating disorders are very straight up, talk about the signs and symptoms, talk about the causes, talk about what can happen to your body. Okay, just straight up. If your potassium goes wonky, you could get a cardiac dysrhythmia and you could die. Your heart could stop. So we just talk about it, you know. What regular old plain good nutrition actually looks like. Okay, and then of course all the therapy and stuff that comes in. So for kids, really, pica we talked about. Rumination disorder, this is kind of weird. I've never seen it personally, but it's out there. This is when they repeatedly regurgitate their food, rechew it, re-swallow it. Yeah, they just keep doing this. I don't know what they do for this. I'll be honest, I don't know. I know it's out there, but that's all I know. And then avoidant restrictive food intake disorder is when kids, so kids can be picky eaters. Kids are weird eaters. I'm just going to say that. Any of you have kids, you know this, right? They have to have the grilled cheese, and they're going to have just the grilled cheese, and they're not eating anything else. I got a phone call from my husband one time. I made her grilled cheese. She won't eat the grilled cheese. I said, well, did you cut it in party sandwiches? Did you cut the crust off? Because if you don't do that, she's not eating it. You know, well, then he did. And I said, that's ridiculous. I shouldn't have to do that. No, you shouldn't. But for whatever reason, right now we're doing grilled cheese cut in party sandwiches with the crust cut off. I don't know, you know. So they do these weird things, and that's okay. But if it comes down to failure to meet their needs, then it's a problem. You know, if all they're eating is one food group, and now they're starting to miss the nutrition portion, we're not able to get them there, then maybe we're going to have a problem, you know. But if they're getting there and it's just because they're kids and they're weird, that's okay. You know, we can live with that. And restrictive eating, remember, any kind of restrictive eating, no matter what the age of the person is, it's about control. Their desire to be able to control their environment somehow. So if we take it back to that. So they get retrained on their behaviors. There's a lot of family therapy that goes into that. Nutritional supplements. My second kid was as wiry as my first, so when she turned 1, she weighed 17 pounds. She was just a little spreader thing. And she was hell on wheels. I mean, that kid ran around, you know. She ate everything on her plate, and half what was on your plate. I mean, there was nothing wrong with her. But I took her for a checkup, and the doctor was like, oh, you know, we need to give her supplements. She's really small. I'm like, okay, all right, you know. So he wanted me to give her Pediasure, which, by the way, if you ever taste it, tastes like garbage. It's just disgusting stuff. It's like Ensure for kids, you know. So I'm giving her this. Well, now she won't eat a meal because it's filling up her tummy. So I went back to the doctor. I'm like, do you want her to eat food or do you want her to eat this? Because we're not doing both. You know, she's fine. She's healthy. So we cut that out. So, you know, if a kid isn't eating, they're not getting their nutrition and they need it for those things, then that's good. If they're doing their thing and healthy otherwise, it's all right. And then we can give kids meds too. You know, we talked about that. And usually SSRIs, because they're the most common. And we know the most about those in kids. Okay? Okay, so autism spectrum disorders, there's two things for kids. We're talking about autism spectrum and we're talking about ADHD. We're not going into the other ones. You'll look at things like oppositional defiant, stuff like that. We're not talking about those, all right? And that's because these are super common, and these will be the behaviors that you'll see in nursing or wherever you're at, probably the most. We don't call them Asperger's disorder anymore. We don't call them pervasive developmental disorder anymore. If you hear those are old terms, it's all autism spectrum. Because we know that people can fall in all different places on this. It can be very mild, it can be very severe, okay? But the main things are they have problems socializing and communicating, and they often have repetitive behaviors, okay? Certain things they do over and over. And again, it depends on the severity, and how you note the severity is what they're doing, okay? Their functional ability, how they communicate, that's how it's graded out in terms of severity. Some people just come across a little bit odd. Maybe they don't make a lot of eye contact. Maybe they don't prefer to be touched, and that's it. And so unless you knew them really well or had a relationship with them, you might not even realize that they were on the autism spectrum, okay? And then you have a person who may be mute, you know, to that extent. And then that you're off on the more severe end. So there's a lot in between, okay? So to get a diagnosis, stereotype, repetitive movement. So sometimes these kids will arm flap, okay? Sometimes they spin in a circle. This is really common as well. Repeated use of words. They really, really resist change. They don't like it. I mean, there's lots of kids that don't like change, but these kids, if you take them out of their routine, they kind of lose their mind a little bit. And I'm not saying that to be mean, but that's what happens. They need their routines, and if you mess with the routine, it's really difficult for them. They get affixed to interest. That's sort of abnormal in intensity. In other words, where one child might pick up a car or thing to play with and play with it for, an hour, whatever time kids do, and put it down, this kid will play with that for days on end. That's their